This is a lecture on adult acute lymphoblastic leukemia. Acute leukemias are diagnosed when bone marrow or peripheral blood contains 20% or more of blast cells. The type of blast cell, whether myeloid or lymphoid or mixed in lineage, will differ in appearance under the microscope, in the amount and type of cytochemical stain that these cells take up, and by immunophenotype, which is defined by flow cytometry testing. WHO requires immunophenotyping to be done to define the identity of blast cells. These blasts multiply in the bone marrow and invariably cause suppression of normal hematopoietic cell growth, leading to cytopenias. ALL is characterized by the accumulation of lymphoblasts. Patients usually present with symptoms related to bone marrow failure, i.e. symptomatic anemia, increased rate and severity of infections, and easy bruising or bleeding related to thrombocytopenia. Infiltration of various organs by lymphoblasts can eventually cause symptoms related to dysfunction in that organ. Apart from a thorough and detailed clinical history and physical exam, it is also important to find out regarding the available family support and the number of siblings that they have, as they may be potential bone marrow donors in the near future. This list of investigations is by no means exhaustive, but the most important investigations are shown. The finding of blast cells or pancytopenia from the blood count is what usually prompts all further investigation and a suspicion of ALL. This is an example of the blood count taken from an ALL patient at presentation. Patients may present with very high white cell counts or have pancytopenia, varying from severe to near normal. Therefore, it is always important for the hematologist to scrutinize the blood film, and for the attending doctor to look through all the parameters in the blood count. Here, the abnormality is very obvious. This patient has a white cell count in excess of 500,000, with anemia and thrombocytopenia. Notice that the report shows blasts of 94%, but does not report whether they are myeloid, lymphoid, or mixed phenotype, or even blastoid in nature. As mentioned earlier, we need morphology, cytochemistry, and immunophenotyping to classify these blasts. This is another example of an ALL blood count. This patient has a seemingly normal white cell count, but further inspection reveals that 52% of these white cells are actually blast cells. The differential diagnoses are not many, and most of the time ALL diagnosis is straightforward once the marrow investigations are done. Patients who present with pancytopenia with no circulating blast cells detected may be mistaken to have other bone marrow failure conditions, like aplastic anemia. In patients with Ph-positive ALL, CML in lymphoblast crisis is a consideration. Immunophenotyping is required to differentiate ALL from acute leukemia with ambiguous lineage. According to the FAB classification, acute lymphoblastic leukemia can be morphologically categorized into ALL-L1, L2, or L3 subtypes. ALL-L1 is characterized by lymphoblasts which are uniformly small to medium in size. They have very high nucleocytoplasmic ratio, and they have quite inconspicuous nucleoli. Under the microscope, ALL-L2 usually consists of a mix of small and large lymphoblasts which have more abundant cytoplasm, irregular nuclear outline with more obvious nucleoli. ALL-L3 is another name for Burkitt lymphoma, a mature B-cell malignancy that may present with circulating lymphoblasts. And these lymphoblasts are large and have moderate to intensely basophilic cytoplasm and vacuolation within the nucleus and cytoplasm. This is an example of a flow cytometry report taken from a patient with ALL. The X and Y axes represent cell surface expression of various antigens. The first plot shows an area highlighted in red, which represents cells that express mild to moderate CD45 on the Y-axis, and which have a low side scatter on the X-axis. This is a blast gate, and all the subsequent plots study the surface expression of these cells. Depending on various combinations, flow cytometry is able to distinguish and quantify abnormal and normal cells. This report shows cells expressing immature markers, i.e. CD34 and TDT, as well as CD19 and CD10. This picture is consistent with a B-cell ALL. Karyotyping and molecular studies are important in ALL prognostication, especially the finding of translocation 922 and MLL gene disruption. Improvement in cytogenetic, molecular, and flow cytometric analyses has seen these techniques take on a central role in ALL prognostication. Age remains important, as older patients may not only have more resistant disease, but generally are not as fit as younger patients in terms of tolerability to chemotherapy. Treatment involves induction chemotherapy, followed by consolidation or post-remission therapy. CNS prophylaxis is crucial in ALL. Overall, long-term survival in adult ALL is in the order of 30 to 40%. When blast cells are very high, there is a worry of hyperleukocytosis. Tumor lysis syndrome is particularly common in ALL-L3 or Burkitt lymphoma. There are a few induction regimens that can be used, depending on the treatment center or hospital. Generally, they combine various lymphocytotoxic drugs. Example is the Hyper-CVAD regimen. Post-remission therapy is important to consolidate the effect of the induction phase of therapy. This can be done with chemotherapy and hematopoietic stem cell transplantation. The tyrosine kinase inhibitors have allowed molecular targeted therapy in Ph-positive ALL patients. On the horizon is MRD monitoring by flow cytometry, which has shown promise and may turn out to be the most important prognostication tool. At present, this technique is used in different ways and generally lacks standardization in terms of the best time of when it should be done in relation to the chemotherapy cycles.